Hi, my name is Lionel D'Souza. I'm an interventional gastroenterologist here at Stony Brook. I'm the chief of endoscopy and the director of our Center for Interventional Endoscopy here at Stony Brook Hospital. It is my pleasure today to give you a talk on the role of endoscopic ultrasound in the various GI malignancies that we see. Everyone's familiar with ultrasonography, which was derived from sonar technology during World War II, and essentially involves a device that sends out high-frequency sound waves to help map terrain. Essentially, the sound waves go and they hit things like rock or a sea or a river, and send back signals to the device that helps them get a 2D representation of what is actually going on around there. And the same technology can be applied to endoscopy. Endoscopic ultrasound scopes have a tiny transducer at the tip of the scope that goes down your mouth into your esophagus, just like any other endoscopy. And from that probe, it sends out these high-frequency sound waves. And what it allows us to do is see things that are outside of your GI tract. So if we want to look at your pancreas or your liver or a tumor in your pancreas or a tumor somewhere else, it allows us to actually see these things without having to cut you open or go into the body. And because we're able to do this without any incisions, it allows us to offer minimally invasive options to all our patients who have cancer, whether it's diagnosis and you need a biopsy of something, of an organ that's outside of the GI tract, to stage cancer so that we can determine what the right treatment options are for you, or also for any therapeutic interventions, whether it's pain control, relieving a blockage, whether it's in your intestine or in your bile duct. Talking about staging of cancers, essentially staging of cancer is giving us an idea of really to see where the cancer is at that point in time to determine what the right treatment is going to be for that individual. Now, when it comes to cancers of the esophagus and the stomach, the endoscopic ultrasound is sort of the standard of care for staging. And the things we're looking for are how deep into the wall of the stomach or the esophagus the cancer is going. Because depending on how deep it goes, that determines the stage and what the right treatment is at the beginning. Looking at lymph nodes to see if there are any lymph nodes in the area. Some lymph nodes can be benign and inflammatory, and some other lymph nodes can be malignant. And knowing what these lymph nodes are, again, allows us to determine what the right sequence of treatment is. So, for example, if there's a lymph node and we don't know what it is it benign, is it malignant, we're able to get a biopsy of that lymph node, give that information to your oncologist, and then they can determine what the right sequence of events is. So, for example, if you have a tumor that's very early and just sort of in the wall without any lymph nodes, a lot of patients go straight to surgery. If there are lymph nodes or if the tumor is going deeper into the wall, then the right treatment is to have some chemotherapy first, shrink that tumor, and then go to surgery so that way your surgery is going to be a lot more successful in curing your cancer. It's also useful in the staging of other cancers in the GI tract, for example, cancers in the pancreas, giving surgeons information in terms of whether it's going outside of the pancreas, whether it's involving any of the blood vessels in the area, in the vicinity of the pancreas, and then also seeing if it's obstructing structures that are around the pancreas, things like your bile duct. And then with rectal tumors, which can be hard to stage sometimes because of the limited space within the pelvis, a lot of structures around the pelvis, in the same way that we use it for cancers in the stomach and the esophagus. In rectal cancers, we can determine how deep into the wall it's going, and also whether there's any lymph nodes in the area or whether it's involving any of the structures like the bladder, the ureters, the bones. And these things are very helpful to your oncologist to determine what the right sequence of treatment is going to be. This is an example just to show you how we can see things with the ultrasound. The slide on the left shows you the different layers of a regular wall of the GI tract. There's usually about 5 layers going from inside out. And depending on which of these layers the tumor is going through, that helps us determine what stage this is. And as you can see there, we can see very clearly with the ultrasound. Now that's what a normal wall looks like. And then this is what it would look like under ultrasound if you had a small tumor. So if you look at the top right corner there, there's a small tumor there in the esophagus that's protruding into the lumen, but also is not really going very deep into the wall at all. So this is something very early that's likely very easy to treat and most likely would go straight to surgery. So you can see how that information can help guide your therapy. And really the endoscopic ultrasound is the only tool we have that can give us information that's this precise. The other place where endoscopic ultrasound is very helpful is when you have what we refer to as tumors of the GI wall. So these are tumors that arise within the wall, and they're often under the surface. So if someone were to see a lump or bump in the stomach or the esophagus, and they were to take a biopsy during a regular endoscopy, they would just get a biopsy of the surface lining, which is normal, and the biopsy would only show that normal tissue. So it would be difficult to know what's actually under the surface to figure out if that's something we need to remove or something we need to watch over time. But with an endoscopic ultrasound, as you can see on the images there, you can really tell you which part of the wall the tumors are rising from, and that narrows the possibilities. In addition to that, we can actually get a biopsy from the deeper layers of the wall by putting a needle into the tumor. We get some cells, we send it to the pathologist, and then they give us information as to what the tumor is, and then we decide what to do. A lot of these tumors tend to be benign. Most of them tend to be benign and often require just continued surveillance to make sure they're not growing or changing in any way. And if they get to a certain size, they can be easily removed, often endoscopically as well, mitigating the need for any invasive surgery. It's an important tool for the diagnosis of certain cancers. So when we think of sort of tumors in the pancreas, in the bile duct, in the liver, or in the lymph nodes, things like lymphoma, it can be difficult to get a biopsy of these tissues without having to go in through the skin or surgery where you need an incision. The advantage of having access to endoscopic ultrasound is that we can get biopsies of these tumors without having to do any form of surgery. The idea being if the organs that are close to any part of your GI tract, so if they're close enough to your stomach or close enough to your small intestine, we can see them with the endoscopic ultrasound, and then by putting a needle that goes through the wall of the GI tract, we can get tissue and then help make a diagnosis in the most minimally invasive way. With lymph nodes specifically, it's very helpful to determine if lymph nodes that are enlarged, are they from just inflammation, like the glands that you get in your neck if you have a sore throat. Those lymph nodes can grow in any situation, often due to inflammatory conditions. But if you want to know for sure if this is a cancer that's spread far away from where it started, with an endoscopic ultrasound, you're able to take biopsies of these lymph nodes and get that information to your oncologist as well. A lot of our patients with cancer deal with a lot of pain, often requiring pain medication and other things. And even in spite of that, either the pain's not well controlled, or then they're dealing with the side effects of some of these pain medications, which can range from anything from mild and tolerable to quite bothersome. So there are options where we can offer pain control for our patients, especially for patients who have cancers within the abdomen. There's something called a celiac plexus, which is this nerve center that's in the upper abdomen. With an endoscopic ultrasound, we're able to see it and then inject medications that help numb that nerve center, thereby mitigating a lot of that pain and decreasing the need for any pain medication. We do this by injecting medications like numbing agents, anesthetic agents like Novocaine, or in high concentration of alcohol that kills the nerve center altogether. The pain relief works very well in more than 80% of the patient and can last for 6 months or longer. And one of the advantages of doing it this way is if the pain were to come back sometime in the future, this is a procedure that can be repeated very easily as an outpatient procedure. It takes about 20-30 minutes. You come in, you have your procedure, you go home. The other main advantage beyond the initial evaluation of someone who has pancreatic or any sort of GI cancers is the interventions that we can provide to patients to help alleviate some of the symptoms that are a result of these tumors. And just to give you a basic idea of what a GI tract looks like and the bile duct and the pancreas looks like, you can see that there are different parts of the GI tract that are very close to different parts of the liver, the bile duct, or the pancreas. And depending on where the problem is and what the problem is, when we're doing an endoscopic ultrasound and we're inside your stomach and inside your small intestine, we're able to access different parts of that entire system, the biliary system, and relieve obstruction or put a stent in or get you prepared for surgery by fixing things like jaundice. So draining your bile duct or your gallbladder for the sake of improving symptoms and decreasing jaundice, I think is sort of the cornerstone for one of the things we do for our patients with diseases of the pancreas and the bile duct. These applications have grown significantly in the recent years, and in patients with malignant obstruction, they really have become an indispensable part of that treatment algorithm. We can treat obstruction in the bile duct, which is a duct that connects your liver to your small intestine, carrying all the bile into your small intestine so you can digest food. The same can be done when you have something obstructing the bile duct, a gallbladder. For example, if there's a tumor blocking your gallbladder, traditionally the treatment will be either surgery or putting a tube through the skin into the gallbladder and letting it stay there. Now we're able to do things internally so that you're not stuck with a tube and you don't need a surgery you don't have to go through a surgery that you may not need otherwise. Symptoms when you have any obstruction to any part of that bile duct tree is things like jaundice. If the jaundice gets really severe, you can get a lot of itching because the substance that the yellowness in the skin can actually be very irritating and cause a lot of itching. If they're obstructed for a long time, you can cause an infection, which can be especially risky when someone's getting chemotherapy. And then you get symptoms like, because the bile's not going into your small intestine and is backing up, you get dark urine and your stool looks very pale. These are all symptoms that you can look out for if there's any concern for any obstruction of the bile duct. So in general, what we traditionally like to do, like you can see in the video in the top right-hand corner, is we usually go in through the opening of the bile duct in the small intestine, and this is where we're able to access the bile duct and relieve any obstruction there is. Whether it's a tumor, whether it's a stone, we're able to do things keeping the anatomy the same. Surgery may not be the best option in patients who are dealing with cancer, who are undergoing chemotherapy or radiation, because the risk from surgery can be higher. The healing can be worse, and it's something you want to avoid when you can. Getting percutaneous treatments like tubes that go through the skin, they work very well, but then you're stuck with a tube sticking out that can have issues of its own. They can cause pain, the tubes can get clogged, they can move, they can get displaced, and all these require repeated therapies. So trying to fix these things internally, where everything's draining internally where it's supposed to go, is really an advantage to a lot of people. With these sort of endoscopic interventions, the need to repeat these procedures are very, very low, if ever. And in general, they provide a better quality of life. What if we can't get to that opening of the bile duct? Maybe there's a tumor that's causing a blockage of the intestine. Maybe there's a tumor that's completely distorted the opening or blocked the opening completely. Now, again, these were people historically who would almost always require a tube that goes through their skin. But with endoscopic ultrasound, we're able to create these new connections, giving different structures in your bile duct a new pathway so that it can drain directly into your intestine or your stomach without the need for any tubes hanging from the outside, and obviously without any surgery. You can connect essentially any structure that you can see with the endoscopic ultrasound, and we have special tools that allow us to make those connections and maintain those connections for the long term. One example is if you have a tumor that's blocking the bile duct. Most often this is a pancreatic tumor or a pancreatic cancer, and especially if it's blocking it so much that you can't get into your bile duct the traditional way, which is to go through the opening of the bile duct in the small intestine. In that case, what we can do is, with the help of endoscopic ultrasound, as you can see on the images on the right of the screen, you're able to first identify a bile duct that's very dilated. You'll see we have a device, stents, that sort of are on a catheter that has a cautery probe. We make a small hole from the intestine into the bile duct, and then using that catheter, we deploy these stents look like dumbbells. And what they do is the dumbbells keep the bile duct and the intestine together, and then inside the dumbbell, all the bile or whatever else you're connected can flow. We can do the same thing if the blockage is much higher up and everything in your liver is blocked and all the ducts in your liver are dilated. And in that case, what we can do is, with the help of the endoscopic ultrasound, as you can see on that image, part of the liver, a big part of the liver, really touches the upper part of your stomach. So directly from your stomach, we can go into the liver, put a stent directly into the bile duct, and have the whole liver drain directly into the stomach. Again, the advantages are no external drains, and no need for surgery. And very often they work well enough where it drains all the bile, people's numbers go back to normal, the jaundice disappears, any symptoms from the jaundice disappears. And very often jaundice prevents people from getting chemotherapy because a lot of the chemotherapeutic agents can affect your liver. And this allows them to continue their treatment and continue getting better. So for example, this is an image of a needle going into the bile duct through the stomach directly into the liver. We inject some contrast material so that we can actually delineate where your bile duct is. And here you can see this is someone with a very, very dilated, distended bile duct. Once we have that access, we're able to put our wires and our tools into your bile duct in order to do any array of interventions. In this case, we want to relieve that obstruction, so we put in a stent that goes from the stomach through your stomach wall through the liver and into your bile duct. And what that does is you can see the catheter sort of going through. What it allows is now you have a stent that's sticking out of your stomach into your liver and your bile duct, allowing all the bile to drain directly into your intestine and still do what it's supposed to do, which is help you digest food. And we're able to leave that in there for as long as we need to. One of the advantages of this is even if you need something in the future, let's say the stent gets clogged or the stent moves, we're able to use that same tract to fix any of those issues if they should arise in the future. What happens when your gallbladder is obstructed because of a tumor? Now, acute cholecystitis is a condition where the gallbladder gets inflamed and gets infected. Most of the time it happens due to stones, the vast majority of the time. And when that's the case, these people need surgery. But in people who have cancers, especially cancers of the bile duct or the pancreas, the gallbladder can get obstructed because of the tumor itself. And that's hard to fix without being able to treat the tumor or remove the tumor, which very often can happen immediately. So they often need something to temporarily give them relief. And I think this is where, again, endoscopic ultrasound is very helpful because it can create a new connection from the gallbladder into the intestine and thereby allow drainage to occur, allow the infection to get better, and relieve the obstruction. And with that, it buys people time. They can get treatment when the cancer improves, maybe they don't need the stent anymore, or if the plan is for someone to have surgery sometime in the future, it gives them time to get ready for the surgery, have the surgery, and at that time get everything that needs to come out, including the gallbladder, to come out. This is an example of ways we can treat gallbladder infections. We can put a stent that goes directly from the gallbladder into the small intestine. It's a very long plastic stent that sort of one end sits in the gallbladder, the other end sits in the small intestine. And this allows whatever is in the gallbladder to drain out into the intestine where it's supposed to go. And that by itself can relieve an obstruction. When that's not possible for some reason, again, using that same sort of dumbbell-shaped stent, you can create a new connection from the gallbladder, as you can see on the image on the right, directly into the small intestine. So now everything drains out, the gallbladder decompresses, the infection's better. And here's an example of how we do that. So that's an endoscopic ultrasound image showing the gallbladder, which is distended, and a catheter going from this duodenal wall, your intestinal wall, directly into your gallbladder. Once we have that access, we deploy that dumbbell-shaped stent, and you can see the end of the dumbbell there on your image. And then the other end of the dumbbell is in your intestine. So now we've created, again, a new connection, allowing your gallbladder to drain easily into your intestinal tract, relieving any obstruction, any symptoms you may have from that obstruction. And then lastly, the other thing that's very helpful with endoscopic ultrasound is very often in patients who have cancers, especially of the pancreas, of the stomach, of the small intestine, if these tumors grow large enough, they can actually occlude the lumen of your intestine, thereby preventing things like food and liquids from passing through. So when patients have this, unfortunately, it's miserable. They can't eat, they're always nauseous, they don't get the nutrition they need, and this prevents them from getting the treatment that they need in order to treat their cancer. So it's a terrible consequence of cancers that we see very often. And it's something that we really need to try and improve in order for patients to get treatment. Now, in the past, the treatment's always been surgical, where the surgeon goes in, they make a new connection, connecting your stomach to a different part of the small intestine and bypassing that area that's blocked, so that now whatever you eat and drink can go directly into your small intestine further downstream from where the blockage is. Again, because of the advances in technology in the recent years, we're able to do this endoscopically now without the need for any kind of surgery, which involves creating a new connection from the stomach into the small intestine. And if you look at the schematic at the bottom of your screen, you can see the stomach where there's a big tumor causing a blockage in the small intestine. So what we do instead is we find a window where there's a part of your small intestine that's close enough to the stomach. And then using that intestine, we use a stent to connect the stomach to a different part of the small intestine. So if you look at the last image on the right now, everything you eat and drink now can go through that stent into the small intestine, completely bypassing the area that's obstructed, thereby relieving the obstruction, allowing people to eat and drink, get healthy, get the nutrition they need in order to tolerate the treatments that they need. So here's an example of how we would do this. This is a patient who had an obstruction of the intestine from a tumor. You can see as we're going into the stomach's very distended, filled with fluid. And because of that, it's sort of a sign that this individual wasn't able to eat or drink anything, terrible nausea, vomiting, not able to get the nutrition they need. So what we often do is like I mentioned earlier, is we try to create a new connection. So we get beyond the area where the obstruction is, and we access the part of the intestine that we're going to use to create that new connection. And once we have a little tube in there, we fill it with fluid so that it gives us a big target to hit. And you can see there the intestine sort of distending and giving us a big target. Then using our device, which, and the help of some cautery, we make a small hole that goes from the intestine from the stomach into the intestine. And once we have that connection, we start deploying that dumbbell-shaped stent again. And what it does is, again, dumbbells keep both your stomach and your intestine together, and it's a wide open stent that allows food and liquids to go through directly into the intestine, bypassing the entire area that's obstructed. And as you can see here, this is the stent on the stomach side, and we stretch it open so that now you're able to eat and drink. And there you can see we actually have a nice connection from the stomach going directly into your small intestine. In conclusion, endoscopic ultrasound has become an integral part of the management of any patient with any GI cancers. As I mentioned throughout this talk, the technology has advanced to a point where we're able to offer a wide array of options for patients with cancer. This includes diagnosis and staging, which is the essential initial part of any cancer diagnosis to help determine what the right type of treatment option is for you. There's the interventions that we're able to do with the help of endoscopic ultrasound allows us to alleviate symptoms that range from obstruction of bile ducts, gallbladders, intestines, and relieve that obstruction in a way that allows patients to continue having a great quality of life. In addition, people with pain, which is very common cancer-related pain, endoscopic ultrasound gives you another option to help treat that pain. So in general, endoscopic ultrasound has become an integral part of any cancer treatment, any cancer center, and we work very closely with our oncology colleagues to tailor treatments to individuals to best help them reach their treatment goals. Thank you for your attention today. It was my pleasure to give you an overview of what we can do with endoscopic ultrasound. For any information, contact the Cancer Center or our offices, and we're always available to help with your cancer treatments. Thank you.